how do you determine which patients with localized prostate cancer or metastatic hormone-sensitive cancer are at risk for progressing to CRPC? Now, we know it's obviously the high-volume disease, maybe bad molecular markers, but are you like really watching out for these patients? They can turn into CRPC they're not going to be your patients who'll stay on ADT and ARPI for a good 2-3 years. Like what kind of characteristics you watch out for in that patient?
The initial staging, the Gleason score, the initial PSA, and whenever I see Gleason 9 or high volume disease in the area and high PSA, I will always be scared those are gonna come back and get resistant.
And I don't know, this is an age log kind of situation, because it's not the same at 80-plus-year-old, that if I get a patient that is diagnosed at 50, because naturally the patient is going to be longer, and we have more treatments options. I think that patient will be at some point, at risk of castration-resistant prostate cancer. So I think that age also plays a role in the possibility of getting this. But I agree with Dr. Haddad, high burden of disease, a presentation, high PSA, and for me, age is a factor too.
Age and whether
I would say there are maybe two more things. One is if a patient's PSA didn't nadir particularly low, so there's a lot of data now of PSA below, nadiring to less than 0.02 versus less than 0.2 versus less than 2. So depending on what category they're in, if they're sort of hovering around and they're still detectable, you worry about those patients. And this is, again, where the genomic data can help. It's not going to change your management necessarily, but if somebody has an RB1, a TP53, P10, you're much more worried about those patients in terms of having a shorter time to CRPC.
So in those patients, you might consider early chemotherapy, or if younger patients and fitter,
I also look for people who've undergone definitive therapy. Earlier recurrence tend to do worse than people who recur much longer after either radiation or surgery.
What's, when you're seeing a new patient with mHSPC, and now we have, a wealth of choices, luckily, like what's your biggest goal? Like what do you tell your patient, my goal is to make you live longer or avoid chemotherapy or delay progression? Like how do you explain it to your patient coming to your clinic? Chris, I'll start.
Yeah, I think maintaining or improving your quality of life and improving overall survival, helping them live as long as possible with a good quality of life. I think that's and especially in the castration-sensitive setting, a lot of that is just trying to say, hey, I want to keep you on this therapy, and hopefully, in the best case scenario, it works for a long, long time, and before we run into castrate resistance.
Do you ever take age? Is there an age cutoff for offering chemotherapy for you? Or is it like the physiologic age?
It's not the physiologic age. I mean, how the patient looked, the functional age. And I give chemotherapy to many 80 years old and tolerated well. So it's how the patient looks, and I now use our geriatric colleagues to help with the assessment too, especially if I feel they are borderline, if there is any physical therapy program that can help them, or any optimizing of their pre-treatment condition.
That's really a great point. I think we need to incorporate more of that. So are you doing that routinely for your...
So anybody above 75, I do it routinely. Even if they look great, I don't want to miss any small thing that might compromise your tolerance to chemotherapy.
That's really great. I think it's a very good approach to managing these patients. Any age cutoff for you guys, or really fitness?
No strict age, but if someone's in their 90s, what am I really going to benefit? Their life expectancy is pretty short at that point, and we have other options that are much better than chemotherapy. But early 80s that are very fit, sure, I think there's a benefit there.
And so let's say somebody has started ADT out in another hospital, and they're coming to you, and it's been 3-4 months, and this patient had high volume disease but never got chemo. Would you still add docetaxel at that point?
That's a great question, because I believe in the trial they wanted to try to start chemotherapy within 3 months. I would see how they're doing, to be honest with you. I would tell them, I have this thing that I can potentially add that may add benefit, but we're not entirely sure in this exact setting. So it'd be a discussion with them.
And I think, like we've answered the question that docetaxel alone is not the best way to go. We need to add something to it, be it abiraterone or darolutamide, but we've not answered the question whether docetaxel is needed or not. And now we have a cooperative group trial, triple switch trial through SWOG, which will answer this very question. So I think that'll be a great, study to inform us in future.
Yeah, it's very confusing for us because first we try to give everything, triple therapy, and now we're de-escalating. So it's interesting, but I think that there's a good thing because patients are living longer.
Yeah.
So, and then, I agree that, controlling the disease at the beginning and many illnesses is very important, and that will portray how the future will be of that patient. But now in these patients that live longer life, so maybe we can wait to add on, like you mentioned.
And that's how this trial is going to be, start with the ARI and then add DOSI if needed.
If needed.
So let's get into a hypothetical case discussion. So 60-year-old male with Gleason 7 prostate cancer and oligometastatic disease in 3 bone mets, PSA of 57, and the PET scan is still pending, based on your insurance issues or whatever. How will you treat this patient? What's your go-to drug besides ADT? Let me ask each one of you. What's your go-to ARI for the patient?
Well, there are no head-to-head data, right? And these are all things I can take you through my thought process with all these things. I mean, they all have different value adds. Apalutamide, OS benefit can be 1 tablet. Enzalutamide, has a bunch of indications. Darolutamide has fewer drug-drug interactions, and they have a favorable toxicity profile. And abiraterone can be purchased with cash for a relatively affordable price, though it has to be, taken on an empty stomach. So any of them are appropriate. And in an era, I believe Dr. Niraj Agarwal wrote in one of the JAMA journals last year, like, we still don't have people even getting an ARSI with the ADT until I want everyone to make sure we're at least getting that before I get too picky about which particular one.
Yeah.
And going back to age a little bit, like complexity. So for instance, we have a lot of patients with AFib on anticoagulation, so darolutamide could be maybe a better option for less interaction with, because every time you put apalutamide or any of these drugs, interaction with Eliquis, interaction with this, interaction with even many Plavix. So now I think that is a very good option for patients that have multiple comorbidities. I like the idea of abiraterone prednisone because it's very cheap, and it's affordable. But sometimes getting a patient to take 3 pills a day is difficult, especially the compliance with steroids, and then the blood work to check, just to make sure it's not electrolyte imbalance and all that. So I think it's tailored to the patient. Enzalutamide, sometimes dizziness, lightheadedness. I had a significant patient falling, especially elderly, having a broken hip because of that. And so they're like those things that I think that we have to make sure that we take that into consideration as well.
So is enzalutamide still a popular option amongst all of you? Before all these other ARIs, like I was using a lot of enzalutamide, for example, but because of these, side effects that you've mentioned, the crossing of the blood-brain barrier, it's low on my priority list now.
I'm not using it as much as I used to. I use apalutamide more these days, and look at if the patient is diabetic, I'm not using ABI. I go to apalutamide, and I feel like I'm going toward apalutamide more than
because of the once a day
Yes.
convenience
Right.
dosing.
I think it, again comes back to, especially when we're talking to people in smaller practices who aren't affiliated with large academic centers, sort of the basics of what has to be done.
Yeah.
Right? Somatic testing, germline testing, bone mineral density at baseline.
correct.
All the general oncology things first, and to know that the standard of care in general, survival benefits is to give ADT plus a novel hormonal agent. Everything else is nuanced.
Yeah.
Which novel hormonal agent, whether to add chemotherapy, those are the secondary questions. I generally do not use abipred upfront. I like to reserve it for the CRPC setting so that I could mix and match my mechanisms of actions. I don't like to burn it up front. There's some data that came out recently that maybe patients who are elderly don't have an overall survival benefit from using abipred. So I have moved away from abipred in this CSPC setting. I've also moved away from ENZA, as was mentioned, because not necessarily the falls for me, just what I tell patients, it's like a mental fogginess.
Yeah.
You just don't feel quite right. So I sit there much more now. I was using a lot of apalutamide, and now I sit there between apalutamide and darolutamide. And it really comes down in many ways to, what does the patient want? Both are approved, both are available. We'll talk about the data for both of them and limitations in a bit. But I had a patient, for instance, within the last couple of weeks that came, and he said, I'm not going on any ADT and I'm not taking any other pills. So I said, well, how about instead of Leuprolide, we give you Relugolix, which you can always stop and see if that gets better. And how about instead of Abi, we give you darolutamide, which is better tolerated. So there's going to be a place for all of these agents, and kind of knowing which patient to give what to, that's kind of the trick of the trade.
Yeah.
But the basics that all patients should be on doublets is the most important message.
I
That's a
think it's
standard.
really, disturbing to see less than 50% patients actually get the recommended doublet, even in the USA, where we have all these therapies approved. So.
But I liked you're mentioning the bone density, because I do it on all my patients who are on ADT, but you'll be surprised how many times it's missed.
Right.
Yeah.
And there's data that all these things that are kind of level one evidence to do they're just not done. Some of it is knowledge, but I think it's more when we take care of these patients. We're talking about ADT, novel hormonal agents, the possibility of chemotherapy, their bone health, their sexual health, their cardiovascular
Correct.
health, and by the time we get to another scan, it
Yeah.
becomes really challenging.
Yeah.
And it's just like we do general oncology, we do everything for breast cancer, but we don't do the same for prostate.
Yeah. True. Prostate cancer has lagged behind the breast cancer world in terms of holistic care.
I think that we are very lucky, at least in our institution, that we have early referral from urology at the time of diagnosis. I did practice in another practice prior to coming in, and my patient with prostate cancer came a little bit late. So that, I wonder if those patients were in that, percentage of patients that didn't get the right treatment. So they basically come referred to urology when there's metastatic disease. So they miss, window that was very important.
Yeah. I think historically, urologists love to hang on to the prostate cancer patients even when they're metastatic, and we had this issue at my previous institution too. But with all these new therapies exploding, I think they're realizing, med-oncs do have a role in the management. So let's say, you're waiting for the PET scan and you get the PET scan done in a couple of weeks. Now it shows 7 and not those 3 lesions. It's also showing some visceral mets in the liver. So I'm assuming all of you will add chemotherapy at this point for this guy, unless there's a reason not to.
Correct. He meets the high volume disease.
Yeah.
So I would definitely can recommend chemotherapy to him.